does not capture every type of head injury, but it captures 70 to 80% of head injuries. Yes?
If you could change one thing on it, what would you?
If I could change one thing on this tool, I would try to get a question that would pick up brain aneurysms, some of the internal things.
Oh.
Because unless the person discloses that, these questions don't elicit that kind of response. These are all from the outside. These are all external. But if you look at the questions, basically the first one is, have you ever been hospitalized as a result of an injury to your head or neck? And we use head or neck when we're talking to lay people. We don't say traumatic brain injury because people glaze over with that kind of terminology. We have at least 16 people that have either been in or have come through a domestic violence situation that have been screened for head injury. I'll get into that. Basically, so it's 5 questions. This can be as simple as, yes?
Could we have a spelling of his name, the doctor's name?
Right.
Yes, Dr. John Corrigan, Corrigan. He's a PhD, and he's out of Ohio State University. Dr. Corrigan is the editor for the Journal of Head Trauma and Rehabilitation. He is one of the leaders in our field, and a great colleague and a great friend.
Is it possible to get the magnified version, or maybe we can find
If
it
you
on this
Google,
site?
well, if you Google,
Oregon?
if you Google Ohio State University TBI identification method, it will take you to their website, and there are videos out there that role play and will teach you how to screen. You don't have to be credentialed to use this tool.
Right, most of the time that is the case, yeah.
So that's the front. This is the back. And typically, this is how we interpret the screening. This is just overflow. And then I'll go back. Step 3 really has to do with repeated injuries. Many people with a head injury, if you've had one head injury, you're 11% more likely to have a second.
Okay.
Repeated very often relates to sports injuries. A person has played, whether it be contact or non-contact sport. That's typically what shows up under step 3. Worst is defined as 1 moderate or severe TBI. First, TBI with a loss of consciousness before age 15. Multiple, 2 or more TBIs close together. Recent would be within the last few weeks, or a more severe TBI in the last months. And then any other sources. So very often what you capture here is most people don't just have a brain injury. They're dealing with depression, they're dealing with alcohol, they may be dealing with substance abuse, they may be, there could be a mental health component as well. These are the questions. This is our data. I'm not going to spend a lot of time, but we've screened 969 people, not counting the last event, which I hope will put us over 1,000. And basically, so this is the aggregate response to the first question, yes or no. Second question, in your lifetime, have you injured your head or neck in a car accident or from crashing some other motor vehicle, bicycle, motorcycle, or ATV? There's the yes or no breakdown. Have you ever injured your head or neck in a fall or from being hit by something, falling from a horse, falling from on ice, being hit by a rock? Have you ever injured your head or neck playing sports or on the playground? And then have you ever injured your head or neck in a fight from being hit by someone or from being shaken violently? You can see shaken babysitter would be picked up. You can see domestic violence would be captured under this question. The last question really has to do with whether or not anybody that has served in the military, railroad workers, miners, because this has to do with, have you ever been, and sometimes fireworks accidents actually show up here under this question.
I hope it's common.
Yes, very much so. I've got a little bit of data around, because I'm on the underserved work group, one of those 3 work groups that we talked about earlier. So the first population that we really focused on, that were really targeted, were people who were homeless. And over in the eastern part of the state, every fall they have what's called a homeless stand-out. And people come from as far west as Twin Falls. I don't know if you know Idaho, but that's about 2 or 3 hours away. And as far east as Idaho Falls. They come to this homeless stand down, and basically it's the event happens in a gymnasium. I've been able to screen over the last 4 years for head injury. There are other vendors that are there. Voc Rehab is usually there. Some of the student professionals are there. A person can get a shower. They can get a hot meal. And since we're doing good on time, I'm good. Yes.
Can you explain, I'm confused by the difference between bullet point 1 and 2.
87 had more than one head injury. So,
It seems, wouldn't that be the same numbers for TBI? Is that doing different between head injury and TBI? Because
No.
I'm mixed up then, with me.
87 have more than one injury, but 58% of the total likely had an injury of some kind, one or more.
so this figure right here is.
87 of the 58%.
Correct.
Okay, I got it now. Thank you.
This figure is pretty compelling because we're averaging, out of about 1,000 people, we're seeing about 36 to 38% of people that are screening likely. Colorado is working with the corrections department. Their numbers are much, much higher. And obviously, people who are homeless, the number goes from 36 up to 58. That figure supports the literature and some of the published studies that are out there as well.
Do you test in corrections?
We have not penetrated the corrections industry yet.
You predict really low numbers?
In corrections? No. Yeah, no, in fact, I think it would be higher than 58%.
A higher rate of TBI in homeless population.
Yes.
What are the contributing factors? It's not having the comfortable bed to sleep in, or the conflicts with other people, or what are the, maybe it's too stupid a question.
Well, no, that's good. So we've framed it in terms of homelessness, but you're saying, can you drill down even further? What does that consist of?
Because that way we can advocate to our legislatures about addressing the homelessness, and what is it leading to? So that's what I was trying to see.
Well,
it would be helpful to know the answer.
This next slide might help a little. So after the first head injury, there was an 11% chance of a second head injury of the 130 people that we screened within the first year. The three highest causes of injury reported were falls, 31%, violence, 28%, and motor vehicle accidents, 27%. When I started in this field, motor vehicle accidents were through the roof. That was the #1 cause of head injury. That's no longer the case with an aging demographic, falls, and then depending on the population group, violence. So here, this kind of hints at what you were getting at. 8 to 53% of those experienced homelessness have sustained a TBI, which is up to 5 times greater than the general population. And there's the source. 87% of adults with a reported history of TBI sustained TBI prior to becoming homeless, which indicates TBI as a risk factor for homelessness. Fairly recent, 2014.
Losing jobs and all that.
So that breakdown again, here's the 31, 28, 27%. They're the causes. And then of a lesser amount, bicycle, sports-related, medical. Again, this is an N of 130, so it's a small number. Then we took violence. We took the category of violence and other from the prior slide, and we broke it down even further. So even though we screened 130 people, the number of causes was 165 under those two categories alone, which, if you've been working in the field, isn't really a surprise because people have more than just one head injury and they have more than just. Anyway, so here's the falls. Here is being hit by something to cause injury. Here's fighting right here, and then this is obviously the violence in the other category. So we just broke it down just a little bit further. This comes from the Brain Injury Association of America. And you can see the #1 cause falls at 40.5%, motor vehicle, and then you get into some of the violence statistics right here. There's that N of so over the last almost 5 years, it's been 4.5 years. This is our data so far. So you can see if I can get this. There we go. So this is the column on other accidents, which are falls, right here. The motorized vehicle accident, which could be a car, a truck, a motorcycle, or an ATV. One of the things that we found is that, because we have many students that are screening, that we've trained to screen, we were finding that we really had to refine, and we actually categorized some of the categories. When a person is being screened for lifetime history of brain injury, some will start sequentially, some people, and they'll give you lifetime history. Sometimes a person will forget and then want to go back. And sometimes a person's like scattered all over the place. And what we were having difficulty is that students were putting hit in the head. Well, we didn't know. The person was hit in the head. Were they hit in the head as a result of a motor vehicle accident? Was it a fist? Was it, as a result, were they riding a bicycle? So we had, so we went to the CDC website, and we've got like 6 categories. And basically, so we give further instruction for the students so that we know definitively what's meant by being hit in the head. And it took us a year to figure that one out. This is just a breakdown of the individual causes versus the repeated causes. Now remember I mentioned the repeated causes tended to be the sports. Oh, here they are right here. And then violence. And again, with regard to violence, it tends to be domestic violence related. And yes?
I see near drowning on there, and while that's not usually what you would call trauma, it's definitely a hypoxic event. So are they also including hypoxic events from drug overdoses for TBIs? Will that impact your numbers probably?
A little bit, but you can see.
That's a hypoxic event, not unlike it.
Correct.
Yeah.
You can see the numbers pretty small.
Well, I know near drownings are, but considering the mechanism of injury, it's similar to something we're seeing skyrocket. I'm sure they'd like to push that over there for now.
Yes, yes.
Now, we probably see more of that in the prison system and not see.
That makes sense.
Overdose.
That makes sense. You bet. So, under causes, yeah, the person may have more than one cause, which is the reason for the numbers exceeding the 969. This is individual versus repeated, the 3 main causes. Just a further breakdown. So the individual causes in the red, the repeated in the blue, and we've got other violence in sports. This slide just depicts the current age of the participants versus the age at the time of the incident. So a minimum, a max age, and then the mean, 24.1. So who gets referred? We refer people based on one or more of the following, and we went through those. Those are on the back of the screening form. Worst, first, multiple, recent, or other. So here are the findings up to this point under the different categories. So you've got multiple, first, followed by worst, then other, then recent. That's the breakdown of the 969 that we've seen so far. Was a referral provided to the client who screened likely? Sometimes, we offer a referral, but not everyone accepts the referral. So some people said yes, some said no. So what happens next? We follow up. One of the things that we built into the grant was there is a traumatic brain injury quality of life questionnaire. And if you can Google it, it's in the public domain. Anyone can have access to it. And there are, I think, 6 or 7 sections to that quality of life tool. We followed up with the Ohio State University TBI identification method, and then we followed up with individuals, and again, this is a phone interview, and we asked them questions from the quality of life tool. So each individual was screened likely and provided contact information. It was a phone interview. And anyway, and this is where you can find it. This is it. This is the quality of life assessment. So this section right here, what I did is I worked with, I'm getting ahead of myself a little bit, but I worked with the speech and language faculty because this has to do with cognition, thinking abilities. I think it's an N. Basically, this is a Likert scale where we assign a number 1 through 5. If a person scores less than 28 on this, they get a referral. If they choose to speech and language, it's either to our clinic or we have a relationship with a private speech and language pathologist in the community. There are 2 sections. This one, section E, deals with feelings. Section B deals with emotions. These 2 sections correspond with a counseling referral. And I've worked with faculty to come up with a numerical number that would trigger an automatic referral for counseling. I've also worked, we are in the process of building our PT-OT clinic. And I've worked with that faculty member, and I have the criteria set when we begin this fall with the new clinic. He pulled questions from at least 3 of these areas. So I already know numerically what that will consist of. So we have that ability. So those are 3, in addition to the primary care referral, we have 3 clinics that we can refer people to. All of our data is captured in in a program called REDCap. And REDCap is housed, hey, here we go, University of Washington. It's an online, anybody familiar with REDCap? Has anybody used it? So it's free. It's free. And it is with the Institute of Translational Health Sciences through the University of Washington. It's an online secure web application for building and managing online databases. It's wonderful. It'll export into Excel. It'll graph for you. It'll do everything. In conjunction with counseling and speech and language faculty, I talked about the trigger points for referral were determined. So what's the criteria that we use for additional referrals? The person's completed a quality of life survey. They score within certain parameters for both speech as well as for counseling. They desire the referral. They want a referral. If a person has their own primary care doctor, we send the information to their primary care doc. If they have no primary care doc, then we have a relationship with a clinic in Meridian, and we have a relationship with Health West in Pocatello. Health West is a federally qualified health center. Every state has what are called FQHCs. They are required by law to serve people with or without health insurance.
First one in Washington. Yeah.
You've got a conglomerate of FQHCs.
Yeah, that's federally qualified.
And you may have other clinics as well. You know, you may have. Yes, ma'am.
What does that stand for?
So it's federally qualified health centers, FQHC.
And so that's what Chaz is then?
Yeah. Chaz is federally qualified.
Oh, is that what they are here in Washington? I didn't know what they were called.
If it's in Spokane, it is Chaz.
Oh, okay, okay,
CHAS.
okay.
Mhm.
Yeah.
So if the person screens likely, if they have no primary care doc and they want a referral, we send a letter to the primary care provider. And then the primary care provider can refer back to us for either speech and language or for counseling, and soon to be PT-OT. This is just a sample letter that we sent to the primary care doc.
What if the doctor doesn't respond or refuses to respond?
So the doctor, I have yet to get that feedback. And again, I only have 2 primary care locations to refer people to. So I've got Unity in Meridian, and I've got Health West in Pocatello. So, you know, I guess it would be up, you're saying the person goes, the primary care doc,
You know, you go to your personal primary care doctor, and for whatever reason, he doesn't feel that you qualify, so he doesn't want to fill out the form because he don't want to skew the data.
well, I mean, he's gonna be talking to you about it. He's going to have the results from the screening that is gonna show. Now, again, if a person screens likely, it's probably realistic to say that maybe only 30% of the people that screen likely possibly have a bona fide traumatic brain injury. I mean, they may have some other stuff going on. Does that make sense? Because just because a person screens likely, this is lifetime history. It really comes down to symptomology.
Right.
We have people that come through and we say to them, you know, it may be recent, then again, it may have been 20, 30 years ago. And then we say, we typically will pull out the symptomology. We'll pull out symptomology under physical, cognitive, and emotional. And we'll say, if you look at this list, are you having any difficulty in any of these areas? Check off the ones that you're having difficulty with. If they're checking off at least 3 per category, they're having some difficulty. And then asking the person, as part of the screening process, we will say, do you believe that this is a result of the head injury? Sometimes they'll say yes, sometimes they'll say no. You know, I've had this, I've had a history of this or that. Does that help?
Yes.
Yes, ma'am.
When the people have, say you said 30% of people possibly have head injury, and it depends on the symptoms, if they're having headaches or sensitivities, you know, to the sound or whatever, and fatigue and all that, do you kind of inform the PC primary care physician and to make sure as they are trying to work their way in with work rehab's help in a working world that they get the appropriate accommodations at work so they can live meaningful lives?
Yes.
Do you have that component built in with work rehab?
Yes, but it comes down to the screener. So it comes down to the student and the supervision that's gone on, and how much information they've been able to capture. As part of the instruction, I say to students, there's room on that form. Don't be afraid to fill it up. Don't be afraid to write something that you think has some bearing on the situation but is not specific to head injury. Please document it.
The accommodations that can
Yes,
help and
all that
improve the quality
yes.
of life for the person, you know.
And then a primary care doc, you know, would probably administer like a mini mental health status exam or something like that. But then that primary care doc has a network of specialists because he's going to have hopefully,
Yeah.
he's going to have an affiliation with some hospital. Most of them do. Many of them do. This is just the scoring as it relates to what triggers a speech and language referral from that quality of life. And then this is the scoring as it relates to what would trigger a counseling referral. And this looks very complicated and sophisticated. It really isn't. It's a Likert scale. It's 1 through 5. You go through. It's depending on, you know, again, if the person scores you know, less than a certain number, they automatically get the referral. We do offer because that quality of life interview can take 15 to 20 minutes. You guys saw the form. I mean, there's like 6 sections there. It can take 15 to 20 minutes of somebody's time. We offer the participant a $10 gift card to Walmart.
Oh, that's great.
That's a huge incentive, and most places have, you know, there's a lot of Walmarts out there. So